Bismillah Rahman Rahim. As we discussed that we will be doing these classes online for you people. This is the first presentation I'm going to talk about. At the same time, I really admire that your participation and enthusiasm by your messages really inspired me, and also this is accordance with the directions and the guidance given by our worthy Vice Chancellor, Professor Khalid Masood Gondal, who has really proved himself very vibrant and energetic, and thinking that this time should not be wasted and we should be talking and discussing academics online. So this is my first presentation for you people. Hope you people will learn out of it. You go back to your books and study, and you can always give us a feedback. So we decided to talk about a very common disorder which is known as suppurative otitis media. Maybe we have discussed this topic earlier with you people during your rotations and in your class, but I wish, because the topic is too important. The first reason is that its incidence is too high. It is a very common disorder. We daily see patients who come to us with suppurative otitis media. And second is that it has got a very important thing, that is that there is no exams where suppurative otitis media is not asked or not given in your theory papers. So, whenever we talk about any pathology, we must be knowing about the anatomy of that structure. And in this case, we should be aware of what is an ear, what are the different parts of ear. When we talk of suppurative otitis media, obviously it is an inflammation of the middle ear. So, otitis media, so we should be knowing about what are the middle ear cleft and what are the various contents of it. So now this is how you just imagine there's a patient sitting in front of you, facing his right ear towards you. So in that case, this is eustachian tube. So in this case, this is anterior and this is your posterior. So a patient sitting in front of you, and now you imagine that nasopharynx and nose is in front of that patient. So this tube, which has got a nasopharyngeal end and it has got an middle ear end. So this is how this tube is obliquely placed from the nasopharynx and opens in the anterior wall of the middle ear. So this is the eustachian tube, also known as auditory tube. Then this structure is known as middle ear proper. Middle ear proper, we will shortly discuss that it is further subdivided. However, then the middle ear is connected through a channel or a passage known as adytus, and which lends itself into the antrum, which is the biggest mastoid air cells. Mastoid air cells are in groups and they are interconnected, and these are the air cell which contain air and has got mucosa which secretes, which become aerated and is important for the normal functioning of our hearing. So this is the brief anatomy of the middle ear cleft. So put all together is known as middle ear cleft. If we talk about this only, then this is the middle ear proper. Now the patient is sitting in front of you, so obviously what structure you anticipate here, just here, is the tympanic membrane. So you know the tympanic membrane is like this, and tympanic membrane has got an oval structure in which handle of Malleus we can see. Now if we look at this structure, if the superior part, which is above this level, this will be known as attic or epitympanum because it is up. And then there is a part which is in the middle, which is known as mesotympanum. and the part which is left below will obviously be known as hypotympanum. So this is how we can divide. If we talk of on strictly of the middle ear, then this is how we can divide into epitympanum, mesotympanum, and hypotympanum. So discharging ear is the most important feature of this disease, and you can see in this picture how the discharge look like. Then we see how the discharge is just mopped out, and then sometimes it is too profuse and too purulent. This is now if you see how the middle ear contains the ossicles. If you remember, this is how the malleus is, this is incus, and this is your stapes or stapes. So these are the three important ossicles. They are all surrounded by different pouches and mucosa. So this redness is just to highlight that inflammation is taking place over here. Otitis media can, just from the time scale of point of view, you can divide it into an acute, chronic, or subacute. But just not to get confused with the subacute variety, you can simply remember that acute or chronic. So the time is less than 3 weeks and more than 3. Less than 3 weeks is acute, and if it goes beyond up to 3 months or more, then we call it a chronic variety. So just to classify, you can always remember this time scale. Now we should know how severe the problem is, and what is the incidence of this disease. Most children have at least one episode in their 3 years life. This is so common, and sometimes it is unnoticed. Sometimes the patient can bring the babies to the doctor, but in our setups, most of the time this disease is just ignored if it is in its acute stage. Increased incidence is in fall and what we call winter. Only 20% are adult. Most of the time the sufferer are the younger age group. So chronic otitis media, if infection persists, obviously significant hearing loss is associated, because whenever there is a perforation in the tympanic membrane, the sound waves cannot really conduct through the tympanic membrane in its proper way, and the patient will experience a hearing loss. The perforations are like this. If you see, this is how you can see this is the perforation. If this is the all tympanic membrane and this is the perforation in it, which can further be sometimes sorry, which can further be subdivided into central or peripheral or marginal perforations. So in medical terminology, the discharging ear is sometimes referred to as atoria. What are the various risk factors? What we should ask about our patient in history, and what is important from its occurrence point of view. Age we have talked about, younger age groups. Allergies are very common all over the globe, and in Pakistan even dust allergy has reached up to 30% incidence, and in West and America also a lot of allergens are also responsible for giving rise to predisposing or risk factor. Upper respiratory tract infection, if it is not only the nasopharynx, it is tonsillitis, it is rhinitis, it is sinusitis, or laryngitis. They can also be a risk factor. Then important thing is bottle fed babies. Bottle fed babies, we always educate or try to educate our patients that the babies should not be fed in a lying down position, as it is shown over here. So we say that there should be a good angle, that a baby should be kept in the lap. The reason is that the tube, which is in, we will shortly talk about the anatomy of tube, its obliquity is different in adults and different in babies. So it is also said the babies who are not breastfed, they have more chance of developing otitis media. Then craniofacial, we mean any cleft palate or some things. Then exposure to environmental smoke. Now, this can be an active smoking or it can be a passive smoking. They both, in both ways, the smoke is hazardous for this. Exposure to group daycare, where this is a disease of a poor socioeconomic status, and the idea is that there are many babies or many people living in one room. So same is that when once we put our babies into the daycare, here also many babies are together and one disease can get transmitted to another. Immunodeficiency, usually in adults, any state, it can be anything starting from diabetes and onwards. Then family history is the least important. So bacteriology, these are some of the common organisms which we anticipate. These are Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. But it is the most common ones. And there are many other which are isolated. They can be gram negative, they can be bacteroids, they can be anything. But these are the most common which we have talked about. So always remember these are the three important, and this is why it is important to know, because we have to treat them with their sensitivities. So if we know which bacteria we are dealing with, it will be easy to manage. Now, how the disease progresses. What are the sequence of disease? What comes first, then what next, and what next? So these are usually certain stages. The first one is just a congestion. This starts from the congestion of the upper respiratory mucosa. It can be viral, later on it switches over to bacteria. And then the second thing is that eustachian tube, which is usually considered the focus of egress of infection, this becomes edematous. So there will be swelling and the eustachian tube will become blocked. Then obviously once it is blocked, the air in the middle ear will be absorbed. Once the air is absorbed, it will be a vacuum-like situation which is created because of the negative pressure created over there. So as a result, at this stage, the patient will start feeling oral fullness or hearing loss. In the first two stages, there is pain or there is malaise or there is fever-like conditions, but later on it becomes an oral fullness. And then finally, the bacteria starts developing over there. They grow in colonies and then they make pus. So this will be the last stage when they will start producing pus before pre-suppurative stage. This I was just talking how the eustachian tube is. You can see that in adults it is obliquely placed. It's like this. But when we see the infants, here it is transversely placed like this. So this is the difference between the two. It is shorter and it is horizontal in children, and it is bigger and it is oblique in adults. So this obliquity will is a barrier, perhaps not let infection ascend. But in pediatrics, because the disease is more in pediatric age group, so that is one predisposing factor which is established all over. So now what will happen? Something which are very specific and something which are general. Patient can come to you with pain, fever, anorexia, irritability, vomiting, diarrhea, or changes in eating and sleeping habits. But the specific things are here. The first thing I told you is otalgia. The second is atoria or the discharging ear. Sometimes hearing loss and dizziness is accompanying at an early stage, but it is always a part of it, because once you have problem with the middle ear, it is not possible to hearing in a normal fashion. Now, we have finished with the history. We have talked about the predisposing factors. We have talked about the bacteriology. We have talked about the anatomy, and we have also talked about how the sound conduction takes place. After that, obviously, once we finished with a good history, which is very important, then you jump over to the examination. Now you have to examine your patient, and now you have to look for certain signs which will tell us what disease we are dealing with. So this is how a normal tympanic membrane look like, and this is how it goes in a congested way. So sometimes there are a stage when we call it a pre-suppurative stage. In pre-suppurative stage, there is a bulge like this. Okay, and then obviously the next stage will be, there will be a perforation and the discharge will come out. That we call it a suppurative stage. So it depends in which stage patient has presented to you. Maybe he can come early, then there will be just a congestion or retraction, then it comes little late, then there will be a redness, and then even late there will be a nipple like stage which is a pre-suppuration, and finally there can be a stage when the discharge is coming out and you can obviously see a perforation. Now this is what I was talking about, how the bulge is. This is how the bulge is. It is not that hyperemic looking in this picture, but it is very red at this stage. Then you have examined your patient, you have taken history. Now the third thing important in diagnostic triad is to go for some investigations. So these investigations usually we can go for an swab from the ear. If it is discharging, you can find the cause. The important cause in anatomy is the presence of adenoids, which contribute to otitis media most of the time. And then you look for upper respiratory tract infections. You can go for radiology. You can take an X-ray of the adenoids. Then you do the audiology. You establish that your patient is suffering from a conductive hearing loss because the conductive pathway is blocked or is hampered. So again, those predisposing factors which we talked earlier, now the age, the history, and antibiotics, duration, all these things you have to keep in mind. Whenever you prescribe medicines, you should always look for what is the probable bacteriology, what is the probable sensitivity, what salts we can give to treat our patient, how cost effective it is. These all things we should take care. So these are the treatment options. Either you treat it a symptomatic way, you obviously patient has malaise, irritability, fever, and pain. They are all symptomatic. And then you talk about the antibiotics. If you know the probable bacteriology, then you will select a good antibiotic for that specific bacteria. So this is how we proceed. Now, first line antimicrobial treatment. What are the options we have with us is usually the first line we treat our patients with amoxicillin, and then the dose you people know how we can give it. Sometimes it is amoxicillin alone, sometimes it is a clavulanate added with it, and this increases the sensitivity range of the antibiotic. The first line treatment, because in our part of the world where still the prescriptions are not that well seen at the medical store or pharmacy levels, so people buy many antibiotics at their own and use it for a long time. And sometimes the patient, if you take a good history, he will tell you that he has taken 2 days amoxil, then 2 days he has taken Azomax, then he has taken ciprofloxacin, then he is, so in 6 to 7 days time he has changed 3 antibiotics. So this is a very good concept that such patients are at risk of developing resistance to these bacteria. Then if first line treatment does not help, obviously we go to the second line, and second line is that if what is lacking. So if the patients are not settling with it, and then you have to switch over to another antibiotics. These antibiotics can be in other form. You see again Haemophilus influenza, Moraxella catarrhalis, these are, and pneumonia. We have to focus on these. So another treatment which are offered is ceforaxime, ceftriaxone, and other cephalosporins. And this is a common combination which is usually used in the form of amoxicillin with clavulanic acid. This is very effective. Now, what will happen? If it is untreated, infection in other places, hearing loss will be there, there will be a residual defect, and the child may develop problems with speech and language development. Complications are many, but just at least you should know these patients are at risk of developing an acute mastocytitis, because I showed you how the middle ear cleft is. So the mastoid ear cells and the antrum may get infection from the middle ear, and this can give rise to acute mastocytitis, mastoid abscess, which is more troublesome because facial nerve is also passing through the ear, so it is at risk also. Another important thing is tympanic membrane perforation is usually the sequelae, and hearing loss is obvious. This is how the mastoid abscess will look like. It is the place where the mastoid bone is, and then it has got nematization and multiple ear cells in it. This is how facial paralysis, the one side won't be able to close, and facial nerve is a very disfiguring condition. Cholesteatoma, if it is an acute otitis media, least likely, but if it turns into chronic otitis media, then there is a continuous process which can give rise to a cyst-like things, and these cystic things can contain keratin inside, and they produce multiple enzymes which are responsible for erosion. This erosive process is more dangerous because now the infection and the complications are more if cholesteatoma is there. This is how a brain abscess will look like on radiology. It is very localized thing. You can easily diagnose it on radiology, and the clinical symptoms support it. This is how a perforation now look like. You see, this is the perforation. Okay, and this is the tympanic membrane. So if you see, perforation is in between. You can see all over, all around it, it has got a remnant of tympanic membrane. So such a perforation is known as a central perforation. So prevention, we always should talk to the patient parents. How can we prevent it? We have talked about the predisposing factor. All these predisposing factors should be discussed with the parents, and they should be told that how to avoid those predisposing factors, which are just we have already mentioned. This is just a repetition. So we always talk that prevention is something good. People are talking about vaccines. There are many innovations taking place in it, but this is how I think this is the last slide, and I wish that we have talked about acute otitis media in general, and some aspects which are associated with the complications, and some aspects how we treat it. But was just an outline. If you see your books, you will find something more important there, and you can always read about it. Now I wish that you go through this presentation, and you go through your books, and if you have any queries, we have given you an email, and shortly I will be dropping a question, and that question I wish that you reply on email in a handwritten form. This is a very brief question and brief answer. So it is just an exercise so that you are involved in this presentation. Also, you will learn out of it. Thank you very much.